It's my pleasure and honor to introduce Professor Jagdeep Nanchahal. Jagdeep is a professor at the University of Oxford and consultant in hand, plastic and reconstructive surgery. So Jagdeep was my PhD supervisor back in 2010 and has been and continues to be a mentor. His career has been astonishing and continues to evolve. Currently, he spends most of his time running his research program in Oxford. So this spans lab-based research on the molecular mechanisms underlying common surgical conditions at the Kennedy Institute of Rheumatology, all the way to clinical trials at the Kaduri Center. But before this, for many years, he led the plastic surgery unit at Charing Cross Hospital, where he specialized in musculoskeletal recon. He chaired the BOA-BAPRAS group that wrote the standards for the management of open fractures of the lower limb, and was also on the NICE guidance development groups for complex and non-complex fractures. And as if he wasn't busy enough, he also ran a congenital hand service at the Chelsea and Westminster. So we're very lucky to have him today to join us and share some of his experiences with us. So without further ado, Jagdeep, thank you very much. Oh, I'll just unmute you.
Great, thanks very much, James. Very kind of you. So hopefully I'm going to try and share my screen somehow. Is that working?
Yeah, perfect.
Great. So James asked me to share some of my experiences about some work we do in Vietnam. So just a couple of slides about that. So I go with some colleagues from Australia. So the people who started it off is, in fact, this chap who's from Sydney, Peter Scougal. And the course that we attend is in Hue City, and in fact, but it's not like a missionary outing. The course is in fact organized by the locals. So this chap who led the department in Hue organizes it, and Peter and his colleagues help. And currently it's Fu who in Hue who runs it, and these are some of the other people. So Richard, Damien, and I are the surgeons, and a couple of the therapists. And the idea is to go and upskill the local surgeons rather than just kind of turn up, do a bit of surgery and disappear again. And Peter and his colleagues have been doing it for about 15 years, and they asked me to join them about 3 years ago, and I've been going with them ever since. So, but in many ways, I sort of tag along and help. It's Peter and his colleagues who do a lot of the organization. It's spread over a week. So the Monday morning, there is this mad clinic of about 100 patients. And what happens is that they have surgeons attending from all around the country. So there's about 70 visiting surgeons, and they're from all across the whole spectrum. So they range from professors in various cities through to their trainees. And what the surgeons in Hue do is they collect up all of these interesting cases over a period of a year and then bring them along. So you can see, for example, this child with APERTS. Richard's particular expertise is brachial plexus as well as congenital hand surgery. And then from Monday afternoon through to the end of Wednesday, we operate, and you can see that the local surgeons watch, scrub in, and the idea is to try and upskill them so that they can take away certain elements of what we bring and improve the care of their local population. And then for the last couple of days, there's a hands-on teaching. So it's different things from different years. So in this particular year, we're using a chicken wing model for microsurgical training. And Peter's great. On that occasion, he took along a whole bunch of micro instruments, as well as relatively low-cost loops, which he then donated to the delegates to take back so that they could use them on their patients. There's also some interactive lectures, and this is just to show you some of the people who attended. One of the key elements for me is that The visiting surgeons tend to operate in teams, and at the end of the day, we often break. So this is one of our favorite cafes where we go for a coffee and we sit down and we kind of debrief and catch up and see how we can improve things and so on. So that, in a nutshell, is what we do. And then, for those of you who are interested, what I thought I'd do is try and give you some. Well, it's essentially show you a talk that I gave last year, because in the previous year we had a near miss whereby a free flap nearly died on the operating table, and I took the decision that the anastomosis and all the surgery we'd done was okay, but the reason for the fact that we had no flow was most likely due to the fact that the patient had become cold. And all the things that I think we tend to take for granted. And I was interested listening to the discussion from the previous talk. Peter, to take your point that you can slightly overthink things, but I think what those sort of algorithms do allow is for people, particularly in training, to step back and try and think through things in an algorithmic manner, which once you become a little more experienced, you tend to do at brainstem level, and it all sort of seems to flow. And I think this was the case with this near miss case with a problem with the free flap surgery. So because I had assumed, because they do free flaps and they do them throughout the year, that I had just assumed that everything that we take for granted in the UK would happen there, but obviously it doesn't. So what I'm going to do is I'm going to take you through the talk I gave them, and if those of you who find it too simple, you're very welcome to log off. So one of the questions, so I did it there as a question and answer session, but clearly it's going to be challenging trying to do that virtually. So which patients are more challenging? And often patients say, well, the older surgeons will say the older individuals or patients who smoke. But in fact, it's neither of those. The documented risk factors are in fact those associated with cardiovascular disease, obesity, and high alcohol intake. So the people you really need to look out for are the fat alcoholic arteriopaths. This was an interesting paper in JPRAS in 2010, suggesting that in fact, statins given 2 weeks before surgery in the at-risk patients may actually be helpful in terms of flap outcomes. We know that they have a definite role in arteriopaths, and whilst we all assume that this is due to lowering our cholesterol, in fact, more likely statins act in a very different way in addition to their cholesterol activities. So what is it that determines the success of microvascular surgery? I think it's all about flow. If you have high flow across the anastomosis from the outset, then you don't have a chance for a permanent thrombus to form. I mean, you will get that initial platelet, white platelet thrombus at the anastomotic site, just kind of around it as a ring, and eventually that'll, over the period of about 3 to 5 days, will epithelialize. But if you maintain high flow, then you're unlikely to get a propagated thrombus that occludes the anastomosis. So if it's all about flow, then how do you ensure high flow? To understand that, I think you need to understand what determines the flow. And this is the Poiseuille equation for those of you who recall back to your A-level physics days. So it's the perfusion pressure, and it's to the power of the radius 4. So that's in fact the biggest determinant, the vessel that you choose, and inversely proportional to the viscosity. So you can in fact modify or optimize all of those factors. So what about perfusion pressure and viscosity? So perfusion pressure, it's about blood pressure, which you need to maintain. And we'll talk about the fluids that should be administered perioperatively. as well as the temperature, which is why I had this problem the previous year. So in terms of fluid management, clearly it's important to avoid dehydration, which can happen in trauma patients, which is my area of interest. But equally, overhydration remains a huge problem. So we need to think about the insensible losses that can be replaced with crystalloid, and then blood loss, where you occasionally have to administer blood, and if preoperatively the hemoglobin is less than about 11, then you might consider preoperative transfusion. And an indicator that you can use, particularly in the lower resource settings like Vietnam, is urine output. That's readily available, even if you can't measure central pressure or even esophageal Dopplers. And you should be aiming for roughly 0.5 to 1 milliliter per kilogram per hour, which roughly comes in at about 50 mils an hour, or over the course of your operating day, about 0.5 liter. So the patient really shouldn't be filled beyond that. So in terms of fluid management, the crystalloid infusion of the rate of approximately 5 mils per kilogram per hour. And there's now pretty good evidence to suggest that if a patient's received more than 7 liters, then they end up with major complications. There's certainly no evidence that giving albumin is preferable to crystalloids, and definitely not dextran, because that leads to complications. So you should be aiming over a period of about 8 hours of approximately 2.5 liters. In terms of blood pressure, so often the patient's blood pressure will fall. And when I first started down this track, I used to be incredibly concerned when the anaesthetist used to offer to give vasopressors. But in fact, norepinephrine and dobutamine will increase flat pressure as well as, flat flow as well as systemic blood pressure. So you don't need to worry about vasoconstriction, whereas epinephrine will reduce the flat flow. And in general, also try and time it appropriately. So if you can do your preparation of your recipient vessels and raise the flap, and then take a break, and often it falls conveniently at a lunch break to both allow the flap and the recipient vessels to dilate and relax from all the handling, and for you to recover so that you're in optimal condition to do your anastomosis. So those are the key things that you need to think about. Fluid input, and it's very easy to keep an eye on urine output, even in Vietnam, and obviously blood pressure. So temperature, well, we all know it's all about the core and peripheral, but in fact it's not either or. It's the delta T. So what you're aiming to do is to keep the difference between the periphery and the core down to it should read less than 1. And interestingly, low temperatures, so hypothermia, is associated with more infections, and we're all familiar with the various methods we've got here in the UK for keeping people warm. But in Vietnam, it's much more challenging because they don't have bear huggers, etc. So this time round, had them put socks on the patient, wrap the patient up to make sure they're not exposed throughout, so wrapped up in blankets. And we also racked the temperature of the theatre up, which meant my colleague Richard was absolutely drenched at the end of it. So what about determining the site of anastomosis? So as I said, it's that power to the radius 4. So think about the flap choice, but also the recipient vessels. I think the key for recipient vessels is to try and get outside the zone of injury. And I prefer to go for limb trauma, to go proximally, because often distally the vessels can look good, but then you can have an injury and in continuity, and particularly the veins can be thrombosed. So a question that used to perplex me was, well, how do I know what's happening to the endothelium? Because the outside of the vessel may look pristine over quite a significant distance, but you don't know what's happened to the endothelium, particularly in traction injuries. But if you look for those little tiny side branches going to the muscle, and when you find that they're intact, and often you're doing your anastomosis hours or days following the injury, then if you come just proximal to those intact vessels, then you know that the endothelium's likely to be fine. In general, the preference is to use deep rather than superficial veins. They tend to be more reliable. And you're all aware of avoiding the valves and the lie of the vessels to make sure they don't kink. So people agonize over, which ones are better end to side, end to end. Well, in fact, it's whatever's appropriate. If you have size discrepancy, then end to side may be easier. Think about whether your recipient vessels can be sacrificed. So I won't sacrifice the major vessels in the lower limb. And also what you're more comfortable with. And there are theoretical considerations that if you do end to end, then the circular muscle in the media will contract and lead to constriction. Whereas if you make a slit, then it's likely to open the aperture. But I think that's more theoretical. And then think about your vasodilators and should you be using antithrombotics. So what about antithrombolysis? So in Vietnam, the local surgeons routinely have been giving intravenous heparin, and you can look at these systematic reviews showing that in fact there's no difference in terms of flap survival between those that have been anticoagulated or not, but the hematoma risk almost doubles. So there's really no benefit from using systemic anticoagulants. In terms of local irrigation, we all tend to use them, and there's quite a lot of older literature from animal studies showing efficacy. There was one clinical study that reported no effect, but I think rather than saying that heparin irrigation solution is irrelevant, it's probably more likely that now that we're in general, our success rates are well in excess of 90%, that it's difficult to show an effect unless you have very, very large numbers of patients. So with vasodilators, you can think about using the calcium channel antagonists. So a lot of places continue to use papaverin, but remember that's acidic, so it may damage your endothelium, and also tends to leave that white deposit when it comes into contact with serum. So my preference is to use the calcium antagonist like nicardipine or verapamil. It's important to not let your anesthetist fall asleep during the case because it can be quite long and tedious for them. And as I said, it is important to take a break. I try and encourage the anesthetist time to optimize the patients whilst I take a lunch break. And when you come back and the vessels are optimally dilated, you can pick up the last bleeding points and you're all set to go. So in terms of failures, arterial failures tend to occur early, the venous a little bit later. You're all familiar with this and also with that. But it's important to recognize that in fact, those changes, particularly for venous occlusion, they often have to be present for many hours before clinically you begin to notice changes in swelling, color, and so on. So from the time of detection to the time you've got to address the problem, it's actually pretty short. In terms of monitoring, the literature would suggest that if you really want to minimize failure, then you should be thinking about monitoring in total for about 7 days or so. Initially, more frequently and hourly, and then less as time goes on. So in summary, then, and again, as I mentioned, this was directed at my colleagues in Vietnam because of our near miss. Aim to keep patients warm with a delta T of less than 1, adequately hydrated, but important, not overhydrated, which in turn leads to problems. VTE prophylaxis, but you don't need systemic anticoagulation. Take a break because that allows both the flap to optimize, the patient to be optimized by the anesthetist, and for you to be in best mindset and also physically ready to do the anastomosis. And then I think one of the commonest problems is doing the anastomosis and the zone of injury. I think just about all surgeons are very skilled at doing the anastomosis, but it's all these little steps that tend to be forgotten as we tend to focus on the surgical technique and assume that everything that's happening in the background is going on, but sometimes it doesn't. Thank you. Happy to take any questions if you've got them.
Hi, Jagdeep. Thanks very much. Brilliant. I believe we have a question from Justin. Justin?
Hi, thanks. I was actually just typing it, so I'll type it as well. Thanks very much, Prof. Nanchahal, that's really insightful. I had two questions which are somewhat linked in terms of the effect of using hand sewn versus couplers for the anastomosis, whether you think, in your opinion or even in your experience, that has any effect on the outcome. And then secondly, which is linked to that, do you think that the time it takes and the amount you need to handle the vessel to perform the anastomosis affects the outcome?
Regarding couplers, so it's just my personal preference. I'm not suggesting it's a better way of doing it. It's just my personal preference to do the anastomosis end to side. I find it just a lot easier. Technically, it overcomes all of the problems with size discrepancy, which you often encounter in the lower limb. And I've never used couplers for an end to side. I don't think it makes an awful lot of difference. I think that's a case of personal preference rather than any data to suggest that one's better than the other. I don't know whether you've got any views on that, James.
So I prefer end to side if possible, because I learned from you, but also in Taiwan we saw lots of horrendous RTAs where you don't want to sacrifice one of the outflows. So end to side whenever possible, but also I find I prefer hand sewn because you can deal with the vessel discrepancy much easier, I find, and I find I can control the anastomosis much better, stitch by stitch, rather than trying to pull everything through the device. But that may be just my lack of experience with the couplers.
Yeah, I think also because the first anastomosis that we tend to learn as trainees is an end-to-end. People tend to be more comfortable with end-to-end. But as I got into doing the end to sides, I've actually come to realize that they can perversely be, and counterintuitively be easier, because you do the back wall, and then you by flipping the flap over, you don't inset it first, and then you chuck the flap over the leg on the other side, and you can do that. So it's almost like doing two front walls. It's so quick. And so, Justin, to answer your second question, I don't think your anastomotic time influences what happens to. I presume you're referring to spasm. I think most of the spasm tends to occur during dissection. By the time you're doing your anastomosis, everything is already set up. Your handling is at that stage quite minimal. So I don't find that's an issue. And in general, it will vary for different people, but each anastomosis takes me roughly about 20 to 30 minutes. So you're not doing it for very long periods. And I tend to do all veins available. I know that's a point of contention amongst some people. There was a retrospective study looking at, should you do one vein or all veins? And anyway, that particular study came out with saying that the data was slightly better for doing all the veins.
All right, thank you.
Has anyone else got any questions for Prof? If not, I have one. Do you have much experience using the venous Doppler? And if so, do you like it? And what do you think?
For flap monitoring, James?
Yeah.
The short answer is I have very little experience of it. I think the there are this whole, so I did have a slide on flat monitoring, which I took out because I didn't think anyone would be interested in it. Anyway, so when I was still at Charing Cross, I persuaded the trust to get these monitors called the O2C. And what you do is you can essentially tape a probe onto your flap, and the flap doesn't have to be a cutaneous flap. It can be a muscle flap as well. And what the probes do is they measure the oxygen. So it's non-invasive, but they'll measure the flow and the oxygen tension in the flap itself. And if you occlude the vein, the parameters will change within seconds, which never happens clinically. And John Simmons, in fact, created a little app whereby you could see the screen on your phone, so you could go home and and you don't need to worry about who's monitoring it. I think the problem. I thought it was a very neat device made by a German company. The problem was that the software interface wasn't great, and I think their marketing was a bit rubbish. So it's never really caught on. But I think something like that, where you can measure multiple parameters that are relevant non-invasively with a device that can just sit on the surface rather than has to be implantable, is probably the way forward if you want to use technology to help with flat monitoring, which is probably appropriate. You can't have someone sitting there looking at it every few minutes.
Mm-hmm. Mm-hmm. I think Ryan has a question.
I just want to ask you, how have you found working in kind of different settings, better or worse in terms of adopting new techniques or kind of new technologies in terms of how micro is done?
Ryan, are you referring particularly to Vietnam, or are you just referring to?
Exactly. So kind of comparing, say, Charing Cross with Vietnam, I can see that there'd be potentially pros and cons in terms of how to introduce new techniques that equate to kind of less developed and better developed systems.
So I must say I found the Vietnamese surgeons very open to new surgical techniques and indeed any form of new learning. It's quite, in many ways, it's quite a humbling experience to go there. I've never done anything like this before I went there about 3 or 4 years ago. And you realize just how difficult it is, not just for the surgeons to cope, but also for the local population. So whilst it's a communist country, there's co-payment for healthcare by the patients. So they have to pay for their drugs, etc., which most of them can't afford. So you see people lying in recovery, and they don't moan, they don't complain, but none of them have received any morphines despite huge surgery and so on. And the surgeons are very, very open to new techniques, but also very questioning, and they'll come up to you and they'll say, "Hey, what do you think about?" Or and it's not a if you like, a paternal exchange. So it's not as if I'm dictating to them, this is how it should be done. They will come up in a very polite way, challenge it, and say, "Yes, but don't you think the following incision might be better?" And oftentimes that they can be correct. So they actively participate and think, because all of those guys are there by choice, not because they have to be. So it's not a kind of a CME exercise for them.
And is there anything you've ever noticed in Vietnam or that you'd want to bring back, almost kind of reverse innovation? I
think it's probably the attitude which makes me sound like a dinosaur, doesn't it? It's a kind of a can-do, want to learn. There's this very nice chap who I didn't know when I first went there, but Peter's been going there for 15 years, introduced me subsequently. So when we, on the kind of Thursday and Friday, when you go in to give the talks and also run the practical courses, this chap always stands up just and wishes the person good morning and say, you know, good morning, teacher, thank you for coming. Anyway, he happens to be he happens to be a professor of microsurgery in one of the large cities, and he's not being obsequious. I think it's just that they are very open and very grateful for exchange of ideas, because often these guys are relatively isolated and they do the best they can, and in fact, things that we take for granted, which is access to literature and so on, most of them don't have that because they can't, their hospitals don't provide that resource, so they can't access, I don't know, regular plastic surgery journals or orthopedic journals, so they're kind of stuck with what they've got. So this offers them ability to exchange of ideas, but not just with us, but also amongst themselves.
Jagdeep, can you give us an idea of the spectrum of things that you see out there and what you do reconstruction for?
It tends not to be acute injuries because they can't save them up for that 1 week. There is a absolute avalanche of brachial plexus cases because everyone's on a motorcycle or a scooter, and there's no everyone. I'm not sure whether the highway code doesn't exist or is just ignored, but it's a bit of a wild west on the roads. So that's quite common. Burns amongst children. So that often will, so my colleagues from Australia are hand surgeons, so it's kind of like mainly hands, but I do some lower limb stuff too. So that case that I referred to was a brachial plexus where we did a functioning gracilis transfer to restore elbow flexion, and we've done a few of those now. But often the patients will come from far and wide. They're not patients from the cities, and some of them, I understand, will have travelled for days to get there, and in out in the sort of in their outback, they're still cooking on open fires, so the kids kind of fall in and they have these neglected hand burns with contractures and so on. So things that we tend not to see in the UK. Not that I do burns now, but there's quite a lot of interesting congenital malformations that I saw some of them when I used to do that work at Chelsea and Westminster, and I guess places like GOS probably now see more. But overall, my understanding is that the numbers are going down quite rapidly in the UK. My impression in Vietnam is they've got an awful lot of them, and I don't know whether that's just because they save up all these exciting things for us when we get there, or it's the hangover of Agent Orange from all those years ago. And also they manage their trauma, for example, forearm fractures and wrist fractures and soft tissue injuries, and to the best of their ability. So we often end up unpicking that and trying to restore things, because we will take across some more modern equipment in terms of the case, sometimes plates and screws, but also my orthopedic colleagues. So the other surgeons have an orthopedic background. I'm the only one with a plastic surgery background, and they'll do some very complex skeletal reconstruction. But that comes with its own challenges. So for example, there's no image intensifier available, so you have to guess. There's no they don't have any sterile wire or drivers or drills. They're essentially the Black & Deckers that you buy from the hardware store wrapped up in green towels. So which means that if you're wiring, remember you're doing it blind because you haven't got II, but also you can't do retrograde wiring because everything that's inside the chuck is now not sterile. So and whilst we do the microsurgery, and they have quite a nice Zeiss microscope. The trouble is, when you look down it, you can't see very much. And anyway, we think in that warm, humid environment, they've kind of got, so it was donated by the Chinese government a few years ago, but we believe that it's probably got lots of fungi growing in amongst the lenses and so on. So that that adds a few challenges.
Justin, you had a question.
Prof, I'm interested in surgical site infection in trauma. What did you get a feel for, what, just based on what you just said, what the sort of rates they see of surgical site infection out there, how they compare to here, and whether those things actually make any difference or not?
Short answer, Justin, is I don't know. They're very good about the fact that they bring out the patient. They'll bring a lot of the complex reconstructions that we've done from the previous year back for us to see. Mm-hmm. Now, if any of them have had, I don't know, local suture infections or simple surgical site infections, we'll never know. The clinic is very rapid fire. The patients don't speak English, so it's all done as via interpreters, and the patients are very acquiescent and accepting of whatever a doctor says. So you don't really have a discussion. Slightly more of a monologue, which it's not great. But we don't, in that short period that we're there, which is just a snapshot over a week, it's very difficult to know what's happening in terms of kind of local infections and so on. But certainly in terms of skeletal infections, we do see those. So we see, so patients will come in, will present to the clinic who will say, I had for example, an open fracture, and they'll give you a history of it being infected and then malunited, and eventually it's kind of settled down, but now they're left with this mess that you're trying to sort out.
Very interesting.
Tariq, last couple of questions. Tariq?
Thank you very much, Prof. That was a very nice talk, and very inspiring as well. It's very obvious that the experience in Vietnam was enriching, and I just wanted to ask if what your thoughts are on trainees being involved in trips abroad, for example, like the one you went to Vietnam, and if so, what sort of advice you have for us to kind of actively seek out those opportunities and how to make the most of them.
Yeah, so it's interesting. The first time I went, I realized, because before I went, I had no idea that how difficult it would be to do microsurgery down a microscope where you can't see, in the absence of sterile K-wire drivers or image intensifiers. So we've done, for example, a couple of polycization in radial club hands and trying to put a K-wire down, and you can only have K-wires in certain sizes. You end up with a 1 millimeter wire in this sort of 6-month-old thumb, which you can't guide down. So I think that if I hadn't had the experience, I guess, and to be able to do that, to do the surgery in that setting without freaking out, then so if I'd gone at a much earlier stage, I would have found it very difficult. But that doesn't mean trainees shouldn't go. So what we do, the visiting surgeons, what we do is, certainly for all the complex cases, we operate together. So clearly the local surgeons will often scrub in. Well, they'll always scrub in. And the visiting surgeons as well, i.e. all the delegates, many of those will scrub in as well. But Peter, Richard, Damien and I will often work in pairs. And that makes the whole situation so much better, because you could be doing something that seems to be near impossible. But because you're working with a very experienced colleague, then that makes a huge difference. So I think if you're a trainee, that sort of environment will be great. So if you have someone with you who's going to scrub with you, but it also allows you to see cases that you just wouldn't come across anymore here. I mean, I don't know how much exposure any of you guys get to, for example, you know, quite complex brachial surgery or even, you know, congenital hand surgery and so on. So and obviously this is an upper limb type service that the guys from Australia and the local guys in Hue organise. But I guess something similar might pertain for people who are doing, I don't know, craniofacial surgery and so on. so I think it is quite an enriching experience. But I certainly found that working with my colleagues together is just so much better. And then, you know, in the evening we'll go to that cafe and sit down with our smoothie or our coffee and sort of think through the day and try and take it apart and any lessons that we've learned. And that's actually pretty good. It's a great kind of team spirit.
Thank you. That was great.
Can I ask one final question, Jagdeep?
Sure.
Is just going back to Alex's talk beforehand, do you have some kind of reconstructive supermarket type concept in your mind, and do you have a particular go-to set of flaps, or is it entirely dependent on context?
So when I started as a trainee, it was all about the ladder. And the ladder held sway all the way through my training years, which I now think is completely wrong, because it implies you're walking up the rung, and those are the bad old days when free flaps, open fractures will be treated with dressings until they granulate, and then you stick a graft on it, or you put a flap on it 3 weeks after the injury, and then you send it back to the orthopods, and when it passes out, you say, yes, but that's a bone fracture, it's your bone infection, that's your problem. It's not my doing, despite the fact that the plastic surgeon didn't make himself available to do it. So that's the kind of history from when I was a trainee. I think the supermarket concept is good. I think I now do all of that processing subconsciously. So you can just sort of see a patient and look at him and say, well, you know, you've got the following defect. These are the options. You know, what would you like to have done in terms of the following? And I would recommend X because it offers you potential advantages. So, but I think when you first start out, if you're unsure and everything appears slightly confusing, so you know, when you're early years SHO, often that can be the case because you don't really understand. Then I think the supermarket concept is very useful because you can at least start processing things in an algorithmic way. I remember doing a fellowship in the US, and I worked with one very talented consultant there, and he was extraordinarily talented. But when I asked him questions, he used to get very defensive and thought that I was challenging his ability and why he was doing it. But in fact, all I wanted to understand was why he was doing something, well, how he made the choice, because it wasn't really clear to me. And I think these, you know, the supermarket concept or any algorithm that you develop allows you to kind of put everything in some sort of order in your head, so that if you follow that, when you first start, then you don't miss something, and after a while it very soon becomes intuitive. But you've got to have some sort of structure, otherwise you just get lost, you're just floundering. You know, you say, oh, I work for consultant A and he did X, so it always works in his hands, so that's obviously the way to go. And clearly that's not the way forward. As you know, I'm obsessed about evidence-based medicine, and I think you've got to do it in an algorithmic way. You've got to look at what the evidence says, and where evidence isn't available, then try and reduce it to something that's logical and sensible.
Right. Well, thank you so much for your time and sharing all your insights and experiences. That's been fantastic. I learned loads, and I'm sure everyone else did as well.
Great. Thanks very much. Thanks for having me.
Guys.